Good afternoon, good evening, everybody. Thank you so much for joining us, and a warm welcome and a thank you to our panelists from whom you're going to hear in a second. My name is Sandro Galea. I serve as the Dean of the School of Public Health at Boston University, but I'm here today in my capacity as chair of the 3D Commission. The 3D Commission is a commission that was started by Rockefeller Foundation in partnership with Boston University, focusing on how we can bring data to inform our understanding of social determinants to the end of making better decisions. The commission was conceived in early 2019, and the reason for the timing is important. It was before any of us had ever heard of the term COVID. And the idea was that as we have a growing global awareness of the importance of where we live, where we work, where we play, the social and economic determinants in shaping our health, how can we do a better job of using data, all sorts of data, to understand social determinants so that decisions can be made about health with social determinants in mind? The commission was launched in the fall of 2019 and then really unfurled for its entire almost two-year period on a backdrop of COVID. And the reason that's relevant, of course, is because if there ever was a global phenomenon that illustrated how much our social and economic environments matter, it was COVID, because it became very clear very quickly that while COVID was an infectious agent, how it manifested, its cases, its deaths, really reflected the conditions in which people lived. The commission deliberated and came up with a set of principles and recommendations, and we released a report coincident with the UN General Assembly meeting last week. This event is part of a series of regional launches. We're doing 5 regional launches that really aim to highlight the main points of the report by inviting experts to reflect on some of these ideas. Before I turn it over to the experts, I'm going to share my screen and just quickly summarize the commission's work. So this was the commission. We had 24 people from all over the world who came from the private sector, from government, from decision-making, and from academia, and from all over the world. It's one of the data points that informed some of the commission's work. This was from a global survey that the commission launched, asking people, well, what causes health? And of course, what you see is the majority of people around the world continue to say healthcare, which is divergent from where expert opinion is, given the role, the centrality of social determinants. But I think that emphasizes how important it is that we continue pushing the social determinants agenda. This is a model of the social determinants of health that we use in the report, but it builds on a whole range of other models, including the WHO Commission Social Determinants in 2008, where we talk about how politics and governance and commercial forces, neighborhoods, social position, assets, incomes, and behaviors all over the life course contribute to the creation of health. So an agenda that says our political policymaking agenda should be reflective of the social determinants needs to take these forces into account, and one recognizes quickly the complexity of these forces and the complexity of measuring them. This is a schematic from the report, and on the left is schematically how we currently make decisions, where there are a number of competing priorities shown by the red hatches, competing with social determinants, and data sources, new data sources, traditional data sources, all of which sort of compete for space until something makes it into decision-making. An idealized decision-making process conceives of decision-making for health as being at the heart of a web that takes into account the social determinants at all times and incorporates a variety of data sources to say, when we make decisions on transportation, on housing, on the economy, that should have in mind what impact it's going to have on the health of populations. The commission articulated 6 principles after its deliberations, and the principles are shown here. And just very quickly, the principles range from the need to incorporate evidence-informed decision-makings beyond healthcare to think about health. The investments in all sectors should be made with health as a consideration. That decision-making about the health of populations needs to embrace health equity, that health equity needs to be at the heart of a decision-making about health. That all data resources, ranging from big data, social media data, all the way to qualitative and narrative data, needs to be part of informing social determinants. And that data on social determinants of health need to be used in a transparent way, making for more accountable governance, and that data collection should be participatory and inclusive of a range of perspectives, including community perspectives. These recommendations, these principles lead to 4 recommendations, which are, and all the recommendations are worded along the lines of regional, national, international bodies, encouraging the systematic, real-time quality collection of data around the full range of determinants, including, for example, education, housing, economics, to decision makers and communities locally and nationally. The developing of transparent systems of data collection about social determinants of health and being explicit that these will be used in decision-making processes, and embedding follow-through monitoring processes to make sure there's accountability for data-informed decision-making. And last but not least, to center community engagement in acquisition and interpretation of data so that the decisions can be made relevant to their relevant communities. So that's really a very quick summary of about a 2-year process of deliberation by the Commission. I would encourage anybody who's listening to look at the Commission website. It's 3dcommission.health to download the full report of interest. But more importantly, now I want to turn over the stage. And I want to turn over the stage to one of the commissioners, Dr. Joyce Benjamin, who is the Executive Director and CEO of the American Public Health Association. Dr. Benjamin is a physician who has had a long career in public health practice and has really could go on and on about what Joyce has done. But I think he's really has been one of the most influential figures in bringing public health and the social determinants approach to public health forward in the world over the past quarter century. And it's been really a pleasure working with Joyce on the Commission. And Dr. Benjamin is going to introduce the speakers and lead us through a conversation, also engaging the audience. Joyce, over to you.
Hi, thanks, Angela. Thank you very, very much. And let me just say how instrumental this work, I think, has been, particularly as Dr. Galea pointed out at this time in really the world's history, because it is important that policymakers use their skill, expertise, and knowledge of their communities to make decisions. But to the extent that they have the data to support that decision-making, it will strengthen that decision-making and ensure that the decision-making goes on beyond a particular legislative body or elected office, because making good decisions requires good data, so that these, as we always say, good data-driven decisions. And to that end, we have a phenomenal panel with you today. We have 7 different panelists. And what I'm going to do is I'm going to introduce them each and then ask them a question. And then we're going to go through the whole panel, and then we're going to have a conversation about them, just kind of a way to get this started. So with that, I'm going to start with Dr. Harry Eichelman, who is the Unit Chief of Health Promotion and Social Determinants of Health at the Pan American Health Organization. Harry, as the Unit Chief of that division at PAHO, tell us a little bit about how you work to include data in the more holistic work that you're doing with the social determinants of health.
Thanks, Georges, for this question, and thanks for being here and having had the opportunity to read a very interesting report. The data that are needed to make decisions on social determinants of health are not always there. We have very good data systems to look at diseases, at deaths. Even we have better and better data systems that look at inequalities, but not necessarily the ones that monitor determinants of health. Well, they do, they exist. There are data systems on housing and there are on education, but they're not linked to the health sector. So there's a huge disconnect there. So what we're trying to do in the organization is to see how we can package and well, first of all, build the linkages between the different data systems so that they can speak to each other and that they can be packaged in a way that policymakers can use them. Because that's where there's another huge gap. Even if there is good data, they're not necessarily usable for a health sector, for a minister of health. And that's where we have another huge challenge that we're working on, particularly on how to implement action on social determinants of health. We have very short political windows. So if we're not ready at the moment of a new minister or a new decision maker coming in with the right data, we lose that opportunity of making that. So we're very much looking at the scanning of the political environment. What are the windows of opportunity? What is the political interest? Not everybody will have the same interest, or every country has the same interest to use data and make a political difference, because this is about policymaking and this is about politics, of course. And very often also ministers of health, they are not necessarily the best interlocutors or the best placed people to speak with other sectors. And that is another huge weakness, not this health diplomacy that we need to translate those data into action in other sectors is weak. So there's different levels of interaction with the governments, but particularly linking the existing data, bringing them to policymakers at the right moment so that the actions can be taken on the social determinants of health.
Thank you. Next, Dr. Feliciano. She's the director of the Institute for Advanced Study of the Americas, plus professor of the Department of Public Health Sciences at the Miller School of Medicine at the University of Miami. Felicia, what steps can be taken to ensure the evidence-informed decision-making to promote healthy societies goes beyond healthcare and incorporates data on the broader determinants of health?
Georges, thank you so much, and Sandro, and to the Commission. Congratulations, Felicidades, on an amazing report and all your work regionally, including in the region I call home and that I love dearly, Latin America and the Caribbean and the Americas. So I think I'd like to focus on one particular point, knowing that we're going to go back to some of the general issues around politics, and that is around issues of equity and gender. So I would say that today in the region in particular, we've made great steps forward in ensuring that we have sex disaggregated data, that we can look subnationally, that we can look by groups in many parts of the region. But even if the data are not gendered, the leadership and decision-making continues to be so. There's no question, for example, if we look at leadership in the region at the highest levels, ministers of health, that it's a minority that identify as women. It's a minority of governors. It's a minority of sub-regional leaders, and it's certainly a minority of ministers of health also at the regional level. If you look at physicians, though they are the majority of those who study medicine, they are not sitting in the leadership positions or in the institutions that have to use the data for the decision-making. And that's how we get problems like the cultural determinant of health that I think permeates so hideously the region, which is machismo, that's driving so many of the problems that we're seeing in healthcare. And without the leadership to use the data in a balanced way, we're not going to be able to change those sorts of difficulties that prevent effective decision-making. And then the last point I'll make is that it's something I'm working on quite a bit now. I think one of the determinants that is most heinous, that is very sadly most common, and that has received very little attention, violence against women, violence against children, and gender-based violence. And I ask myself over and over again, how does something that affects so many people, 1 in 3 women, 1 in 5 children at the very least, so it looks like pollution, but we have treated it as though it was a neglected tropical disease as opposed to what it is, which is a pandemic and determinant of so much of health. And so I'll go back to this question of, yes, we have data, but if we don't have what we need at the level of leadership, we're not going to be using those data and churning them the way they should go into transformative policymaking.
Thank you, Felicia. So I also like to bring up Stephanie Saki. Stephanie is a senior advisor on human rights and gender equity at the U.S. Department of Health and Human Services. So I think she follows right on with Felicia's comments. So Stephanie, obviously, what does your role in data play? What is the role that data plays in your role as an advisor to some fairly high-level individuals?
Thanks so much, and just certainly echoing those points from Felicia, and also thank you for this report on such an important topic. As someone who has a background in research, and now I'm about 8 months into being on the policymaking side, I think this question is really at the core, and for those of us at the Department of Health and Human Services, this is really at the core of the work that we're doing and the challenges that we're facing right now. So hopefully many of you have heard over and over again that in the Biden-Harris administration, the question of equity is a high priority. It's at the core of what we do. And I can say as a member of the administration that the question of how to center equity comes up in almost every discussion and meeting that I'm in about policy priorities. So it's a core principle, but how do we get from this rhetoric and priority and genuine focus on it to evidence-based, data-driven action? I think there are ways that we are doing a great job, and I think that there are areas for improvement and areas where we would love input and collaboration with many of you. So just to give some concrete examples, and we talked about this already a bit, but obviously the COVID crisis has really brought into stark relief the social determinants of health, I think in very visceral, tangible ways in the United States, even for people who weren't thinking about social determinants of health before. So CDC data show that access to healthcare, of course, but also occupation, income, education level, physical environment, neighborhood, a number of these really important issues are important determinants of risk of exposure to COVID and also risk of hospitalization and death from COVID. So we know in the US in particular, racial and ethnic minority groups are disproportionately represented, for example, in essential worker groups. And that's one of the reasons that we've seen such disparities and exposure to COVID and deaths from COVID. So CDC is tracking this information closely. Hopefully you all are aware that the president created on his second day in office, he created a COVID-19 health equity task force that engages with members of the community outside of the government to make sure that we're tracking and thinking about how to address equity in our COVID response. To give a specific example, CDC started to see much earlier on in the pandemic patterns of high risk of exposure for workers in food processing plants in their ongoing data collection. And so they issued new guidance for those food processing plants to adopt safer measures. I think this raises this question, though, of you can have guidance from the federal government, but there's a lot of other levels of engagement and participation and partnership that are needed to effectively address these social determinants of health. One other point I just want to mention in terms of how data feeds into the work that we're doing, and kind of not the traditional sense of data, but is about engaging with civil society, which has been hugely important to come into the administration, to have a change in administration in the middle of multiple crises and have to take over. I certainly have realized, and I think many of my colleagues have as well, that members of the communities that we're working with and members of civil society organizations who represent those communities are invaluable partners who have been holding down the fort on some of these issues, thinking about health equity, but also sexual and reproductive health and rights, LGBTQI+ rights, many of these hugely important issues addressing climate change. And our partnership with them has been so important to make sure that our policies are reflecting the data and experiences and evidence that's coming directly from those communities. So I will pause there, but certainly have lots of thoughts on the challenges of developing policy based on data as well.
Thank you, Stephanie. Harry talked a bit about some of the challenges that we have. We don't have all the data. I'd like to ask Dr. Sebastian Garcia Sasso, who's the Director for Evidence and Intelligence for Action in Health at PAHO, a bit about his work in ensuring that data is utilized appropriately in order to implement evidence-based policies. And also, if he can give us a little insight as, how do we deal with these gaps? Stephanie talked a bit about gaps, and Harry talked a little bit about gaps.
Well, thank you. And I would like to start by congratulating the Commission for this very significant accomplishment. I think that the report brings focus into the center of what really constitutes the road forward as we seek to improve decision-making and policy-making in health. The use of data to implement evidence-informed public health policies and interventions has always been central to PAHO's technical cooperation. And an example of this is PAHO's Court Health Data Initiative that has, since 1995, implied the systematic collection of subnationally disaggregated data on health services, health outcomes, and also social determinants of health across countries in the Americas. And on the analytical use of data as part of the first public health essential function, namely the health situation assessment. Our department, Evidence and Intelligence for Action in Health, focuses precisely on improving access and use of data and evidence for decision making. makers working at the regional level and supporting member states, countries through technical cooperation on key components in the data to evidence to policy continuum. From the necessary strengthening of information system for health so that data exists and becomes available and usable regarding to this gap. And now, of course, including also the relevant elements of digital transformation of health as well, to producing the required capacity to analyze and act upon the data, going through the generation of evidence and knowledge management, and all the way into how this evidence is then translated to policy and decisions at the local level. PAHO has always considered a holistic approach to information systems, talking about this gap in data and access to this data. PAHO introduced this concept of information systems for health, considering that in today's world, data needed for decision and policy making in public health should come from different sectors, sources, and formats, both structured and unstructured. We managed to position a new paradigm so that information systems cease to be seen then as just a set of technological platforms to organize electronic records and become more of a framework of action that consider aspects, for example, of governance, health data management, the multisectorial and interdisciplinary approaches as a central component of all this. Taking into account, for example, the management of technological infrastructure, the digital literacy, knowledge exchange, standards that ensure interoperability and mechanisms and methods that allow the incorporation of emerging technologies for the application of data science as part of the public policies of the health sector. PAHO counts on a complex and very rich network of collaborating centers that support our work in many different areas. But let me refer to the work on knowledge translation, where PAHO, alongside its collaborating centers, is actively engaged in the development of guidelines and standards to help national health authorities shape their evidence-informed decision-making processes. Something that has clearly been highlighted as a priority in the current COVID-19 pandemic, and that it's also at the center of our approach to social determinants of health and health equity. So working on all these different elements, so this cycle or even a continuum on the strengthening of information systems so that we make sure that the data is available, the data exists, is being produced, all the way to being able to use it, analyze it, and translate it into evidence that it's later also translated into policy. So this full cycle, I believe it's also at the center of this report, and when we celebrate the possibility to be then engaged in this, what constitutes working together towards this end.
Listen, Sebastian, thank you very much. I want to give a big shout out to our next speaker, Dr. Joyce St. John. She's the Executive Director of CARPA. Some of you may not know, CARPA is a Caribbean public health agency. I've had the chance to actually participate in one of the CARPA research meetings. And I got to tell you, it's an absolutely phenomenal research meeting. So I'm not sure when your meeting is this year, but I hope that people will be able to come and participate, because it does exactly what we're talking about. It generates amazing amount of data. And, you know, can you talk a bit about your work there in CARPA and what you're doing to address both, non-communicable diseases and some of the communicable diseases?
So CARPA's annual research conference, the 65th, was held in June this year, and it was our first virtual conference. But CARPA is doing a lot of work. And you've talked about communicable and non-communicable, and I'm going to use them as my segue into the way in which CARPA has worked most effectively in changing data into evidence for policy making. And this was with COVID-19. Very early on in 2020, the heads of government started having meetings about this well, we weren't even sure it was COVID-19 at the time. And they called on CARPA to give them the kind of information that would make them decide what they had to do to fight it, what could be the health and other impacts, and what eventually it turned out to be, what would be their line of attack. And so CARFA started quickly bringing together the data. First, it was less of the regional, CARICOM regional data and more of the international, but we started bringing together the data to show that this had potential to be a huge strain on our health services and our main money earner, tourism. And we started to see how we could devise policies at their direction, which would have been common, harmonized. And so we were able in 2019 in 2020, and for a little bit of 2021, to more or less keep COVID-19 from becoming entrenched and overwhelming our services. And how did we use NCD data? Well, we were determined that we were not going to have the inequities that we saw playing out in other regions, where some had and some did not. We were lucky to get quite a bit of assistance from many partners, and anything that came through us, money, PPE, equipment, reagents and supplies, and the machines that did these things, we apportioned using a formula to ensure equity. And we used not only population data, but the NCD burden, NCDs and the risk factors of NCDs. So we used data not only to let the heads of government know this was something that needed their involvement, needed their leadership, and needed them to call for a whole of society response, but also anything that came our way that would help the member states. We ensured that we used the data to have equity in the distribution of that equipment or money, because we got money, which we used to help the member states, 12 member states, get access to COVAX vaccines. So I think that for the Caribbean, we found ways of executing what this 3D Commission report was saying should be executed without even knowing that this was a framework for action, using the data, speaking the language of the heads of government in a very focused way so that they could see that above all of the competing interests for how there should be a response to COVID-19, that having a health focus, ensuring the lives of the citizens were balanced with livelihoods would be the way to go over.
Thank you very much. So I guess we'll have to wait till next June to come to the next meeting. But that's okay.
No, you can ensure that you get in by submitting a paper. We probably will have the usual deadline towards the end of the year in December. So I'll make sure that you get a paper to
Thank you, Dr. St. John. Dr. Jeanette Vega, who's the Chief Medical Innovation and Technology Officer at Reed U. Salud, UC Christus. Jeanette.
Yes.
So, you know, some of the challenges in South America to ensuring that all decisions about government investments in any sector are made with an eye to their potential health impact as a consideration. What are your thoughts about that?
Well, I think that's a huge challenge because the way that the ministries are organized is that they get their budgets for their specific activities, and there are no budgets that are allocated in general to more cross-government or cross-sectorial activities. What we have seen in the Americas is that we have had some experiences of cross-sectorial work with allocated budget, but those are mostly related to the specific priorities at the presidential level. If that's not the case, then it's extremely difficult in particular from the Ministry of Health, to make sure that the other ministries are in fact contributing to some of the Ministry of Health agenda, which is the same for other ministries. So I think one of the challenges is that when you have an agenda that requires cooperation from other sectors, that agenda can be seen as a win-win agenda where all the ministries involved, in fact, get a piece of the benefits. If not, it's extremely difficult. So I would say that in order to advance the social determinants and health equity agenda, in addition to say that health and health equity is an indicator of social development, we need to make sure that we walk the talk and we specifically provide budget that it is allocated for cross-sectoral activities. Over.
Dr. Vega, let me thank you a lot for that. The commission had a very robust discussion around the importance of doing things and recognized very early on. In fact, I think almost every member of the commission pointed out the importance of multisectorial solutions to health problems. And the fact that sometimes when groups get together in a multisectorial way to solve a health problem, they figure that they can work so well together that they often put that same coalition together to solve other problems in the community. So I think the real solution here is what you said, is that doing this in a multisectorial way makes all the difference in the world. I'm gonna ask one question for all the panelists and we can have a conversation while I'm asking people that are listening who might want to ask us a question from the audience. You're welcome to do so by submitting your questions for our panelists using the Q&A function at the bottom of your Zoom screen. So while people are lining up their questions, let me ask in particular, what steps can be taken to make sure we include diverse perspectives into the decision-making process? As you know, sometimes the people that are making the decisions aren't necessarily a very diverse decision-making body. Any members of the panel would like to take that one on? You can either just raise your hand or just unmute yourself. Harry.
Yeah, thanks. I think this is a critical question, and I think it's very important that we critically look at what we mean by diversity, because there is, of course, and Felicia already touched on that, we have, of course, gender, we have ethnicity, but I think what is, and it's also been very proven very important in the COVID pandemic, what we saw is that the public health measures that seem obvious, wash your hands, stay at home, work from home, study from home, was not taking into account the political and particularly social and economic context of the populations. And that has really hampered our response to COVID. So when we talk about diversity, we need to look at the entire spectrum of the disproportionate difficulties that people in the lower socioeconomic classes had to comply with the measures, but also they were disproportionately affected: the migrants, the homeless, the people living in slums, etc. So I would really like to advocate when we talk about, particularly populations in situation of vulnerability. And of course, in for example, the US, many of those are what we call minorities. But what really underpins this is the socioeconomic conditions and context of the people, how they live, in this case, COVID, but this holds for any of the other diseases. So I would like to put that framework on it. Thank you.
Harry, that's a very good point. Joy.
Yeah, I'd like to follow on from Harry to say that usually when you think of diversity, you think only of color or maybe gender. But COVID-19 showed that there is so much difference and so much difference from the norm and what is captured in the services that are given by governments and NGOs and private sector. That we need to define diversity by that which makes people marginalized. And sometimes that which makes people marginalized isn't just their color or their gender or ethnicity. Sometimes it is the fact that they can't afford to follow the rules as they change. And this really came up in COVID-19. There were people who could not afford to pause and stay home, or there would be no food on the table. There would be no money for heating. And also, we need to think of diversity in terms of functions that have evolved a range of super functions, those who are academically gifted. But we found out in COVID-19 that the people who were not necessarily PhD holders were the people that we could not live without. Supermarket cashiers, the security people, people that we never would notice. So we have to also redefine diversity from the tried and true and think more along the lines of who is made vulnerable by the society constructs and how can we include them.
Thank you, Joy. Let me ask Stephanie if she picked that up from the Department of Health and Human Services perspective. Obviously, you folks have been thinking a lot about this, particularly as we go forward with both the Biden administration's proposals around climate change, dealing with COVID. What are some of your thoughts about how we might build on those vulnerabilities that Dr. St. John talked about?
Yeah, I mean, to give a very concrete example, we have just sort of wrapped up the development of the government-wide strategy on advancing gender equity and equality within the US and around the world, which is a mouthful. It is coming out in the next few weeks. It'll be shared publicly. But as part of the process of developing that strategy, the White House Gender Policy Council organized a series of listening sessions with adolescent girls representing different groups from around the US. And it was and invited representatives from across the US government to just listen in and hear the experiences of these girls representing different communities. And it was incredibly valuable in terms of being educational and just eye-opening. I thought I was not that far out from being in high school in America, but it turns out I have no idea what that experience is like now. It's changed quite a bit. But also, you know, in the process of developing the policy, we were able to go back to those discussions as a touch point and just say, you know, this is an issue that we heard loud and clear over and over again from those communities. And it's kind of a leverage point in those discussions to say, we cannot leave this out. We have to include this. We heard it so clearly. And if we're engaging communities, we need to make sure that their voices are represented. The other piece that I'll just, so I think there's been quite a bit of that, and it's hugely important. And I also would say that representation in actual government roles and leadership roles is hugely important as well. So we can all have conversations with members of different communities, but if you don't have people from those communities who are in the room when decisions are being made, their voices are not going to be represented accurately and strongly in the same way as other voices. That's just a reality. And that's one of the, I think, amazing things about the Biden-Harris administration has really focused every step of the way on representation and leadership roles as well, in addition to engaging with these communities.
Thank you. Jeanette.
Yes, I just wanted to go back to the definition of vulnerability. And I do think that what we are talking here is mostly about hierarchy, and a hierarchy that is related to power, to economic resources in particular, and then to probably to prestige. And if that is the case, the inequities, the inequalities are different in different settings. In some settings are related to gender, in fact, in most of the world. In some settings are related to where are you coming from. In some settings are related to X or Y. But at the end of the day, all of that has to do with the hierarchy of power, resources, and prestige. And so that's why I don't think that talking about things like disparities, even though it's very popular, is a term that represents what we are talking here. We are not talking about differences. We're talking here about inequalities and inequities in particular. And I think it's very important to realize that when we talked about social determinants. And the other thing that I'd like to point out is that it is also different then to talk about social determinants of health than to talk about social determinants of health equity. And we have to make that distinction because they are not necessarily the same. I would argue that social determinants of health equity are much more related to issues that are connected to social hierarchies than social determinants of health. And the problem with that is that it's very difficult to get data on that. And that's one of the complications where we talked about social determinants and health equity, that finding data that are collected systematically is extremely hard. Over.
Thank you. Sebastian. You're still muted.
Sorry, Jeanette's intervention just triggered some of my preferred buttons. And I mean, that's the key issue. And you were asking, what are the steps required? I think in many ways, we need to go back to the basics of we need data. And for that, we need stronger information systems for health. We need to be able to use structured and unstructured data if we're really going to understand not just the situation, but also the context in which this situation is happening, and understanding more about these differences that we've all been mentioning. We've all been mentioning now, and as such, then we need to advance, and we need to continue working to establish data governance mechanisms. We need to strengthen the capacities in all aspects of data management, and here I just refer to essential things like quality, of course, availability, the hierarchy of the data, the definitions. Are we really referring to the same key elements when we seek for data? I mean, if we talk about very basic things like gender, well, many countries and many local settings are asking this in different ways, and this implies we have then differences in the data we're acquiring. The same for ethnicity, for example. Some countries are asking ethnicity in terms of self-identity. Others are on the ability to speak a particular language, for example. So what is it, the data that we're looking for? We need to look at the ethical use of these data, aspects of cybersecurity now as we move into this digital transformation, the interoperability, and many other matters that allowed for health ministers and other decision makers to really be positioned in a strategic and sustainable role within what are now the e-government initiatives. And I think this is at the center of this data availability that we're talking about. And this has been around for some time now, and we need to then interconnect health-related data and social determinants of health with open government portals. And just in short and in non-technical words, if we can get the health sector institutions to position their data sets on open government portals, then we will have taken a step forward in health data management like never before in history. And so if we think that this is what will make it possible to better understand also social determinants in this pool of ever competing priorities and issues to constantly address that the report highlights, and therefore be able to better guide decision making in a more transparent and also equitable way. So if you ask me, what is the first step? Well, we need to, again, look at the availability of data, look at how we're collecting this data, and look at then the principles on how to strengthen this access to data.
Thank you, Sebastian. I want to get Felicia in here. And I know she may have some comments about this thought, but also let her pivot to maybe talk a little bit about sustainability, because the issue is not just to get the issue done, but how do you sustain this over time? Felicia.
Thanks so much, Georges. And I think the pivot is that we know we have some programs and projects that have been demonstrated with data to be effective and to promote equity, exactly in the way my colleagues were saying, and exactly as Jeanette mentioned. And yet, for some reason, and I think we know what that is, even when these programs are proven to be effective, it's politics that gets in the way. The one I have to highlight is in Mexico, Prospera Oportunidades Progresa program, with decades of complex evaluation that was very difficult to finance. It was a pioneer program. Luckily, it sort of spread around the world because it was based on evaluation, but it got closed. It got closed for political reasons. And the question is, why did that happen and what to do about it? So I think we think about sustainability and data transitioning to effective decision-making that does something about determinants and health equity. I had a couple of thoughts for Latin America in particular. And one big problem is we have such volatility of leadership and segmentation in our health sectors that it's very difficult to see any continuity of programs. And that's where I think it's important to think about how data come in. Second, in most countries, we have a real problem with institutional autonomy. So a new government comes in and everything is wiped out. Yet we have examples, and here's something good about Mexico, the National Institutes of Health, where the election process is different and separate from political change. And I think that allows us to do one thing that's so important when we think about the determinants of health in a multisectoral approach, to have institutions that can evaluate government around determinants and in a multisectoral way. That's been difficult to maintain in Mexico, but it was certainly the spirit of what Coneval was all about. I have to say something about protection of data, research, and researchers, because we're just seeing some political leaders, go after our researchers. First, they take away all the funding, and then they go after the researchers if they go against government, if they use evidence in what they fully believe is a correct way. And so the question is, how do we fix that? And finally, I think it's a balance between, let's say, privacy and politics. A huge change in several countries of the region, Peru is one, is that officially we can ask for data by law and through specific institutions. A lot of the years I spent working in Mexico, I had to ask for a favor to get data. And if you knew who had the data, if you knew the person, you got the data. Now we can ask by law in a transparent and reasonable way for the data that we need. And I think that has really changed the game, at least in Latin America, and will continue to do so.
Thank you. We have a question from our audience, and the question says, how can we get or elevate decision makers who truly represent the communities so that they can personally care about the data and implement policies based on it? So how do we get elevate decision makers who are really going to use the data that they care about to make and implement the policies that they care about? From the panel. Any thoughts about that? Because at the end of the day, I think that's the central question. I think that goes to Felicia's point. I'm in an administration, and I want to get credit for all the wonderful things I did while I was in office or I was in charge. And then someone else comes in behind me, and they want to get credit for something too. If you have good data, I can say I took it from from first degree to some number, and then they can come in and really pick it up and say that they advanced it. If you have good data, you can actually make that kind of comment. But if you don't have the good data, it's very tough for you to do that. And of course, then there is always the political will of people to kind of wipe it out and bring in their own initiatives because they've run on the fact that their predecessors' initiatives were no good. But the truth of the matter is, in the United States, I got to admit, Operation Warp Speed that the Trump administration did was really a wonderful thing. It built on 20 years of science, but taking it and getting those shots in the arm was the next administration's accomplishment. So I think that we can do that. We just have to be willing to give the other person credit and build on the systems in a meaningful way. Felicia.
Yeah, I just wanted to add that one thing we knew, but we saw with COVID is how technology can divide people based on access and poverty. And in this world of bigger data and the need to use it, and having said that we need more representation in government, those changes of individuals won't happen if people who live in vulnerability don't have access to education and to the technology that will allow them to actually participate with the data. And I think more and more that's something we're going to have to invest in.
Absolutely. Absolutely. Let me just ask any other thoughts, and then I'm going to have to, in about 4 minutes, turn this over to, because we could do this all day. I'm just pretty excited about this conversation. Let's you know, the 3D Commission has some very specific recommendations, and it's really about how do we get policymakers to use this data. And just short statements. Any of the speakers have any thoughts about if you were, you know, could wave a magic wand, what would you get a policymaker to do to buy in the data? Any thoughts? Stephanie.
Well, I'll just weigh in from the policymaker perspective, which again, this is a relatively new role for me because I spent most of my career on the other side of trying to convince policymakers to make decisions based on data. So one of the things that is striking to me, and I'm sure everyone has heard this, and I certainly had heard this, but to reiterate it, which is that people have so much going on at once and need, you know, top line, here are the 3 takeaways from the data in order to solve the problem that you have on your desk right now. And I think that is incredibly difficult to do for researchers for many, many reasons. And it requires sacrificing nuance and, you know, speaking in a language that is different from the usual language of researchers. But I do think, I'll speak again for the Biden-Harris administration, there is an appetite and an interest, and we are in a window right now of developing policies that reinforce these priority areas. So now's the moment. I think this is a good test case, and I certainly welcome any input or suggestions from anyone listening, and I know that other members of the administration do as well. So it's a good time to test out that top 3 priorities.
Thank you. I've got 3 minutes and 3 speakers. So Jeanette.
Yes, just one sentence. I think that in order to get policymakers to act, you have to make sure that the data are out there using the press and creates public opinion.
Great, thank you. Harry.
I would use my magical wand to make sure that the policymakers really care and really represent the wish of the people that have voted for them, and that are really willing to go beyond the short window of their political opportunity to make long-term impact.
Thank you. Joy.
Well, I think I would want some funding, because often policymakers are pushed into one direction because funding isn't there to help them do what they want. So I would want some funding, but let's forget all about the money. I want to be able to speak a language that they feel, not just hear and switch off, that they feel. And I am hoping that as we move into the post-COVID world, or the post-COVID confusion world, that we have more of that feeling and caring over.
Thank you. I'm going to do Sebastian and then Felicia, and I'm going to turn it back over to Sandra.
Thank you. Well, I would say we need to continue a constant work on capacity building. I mean, Felicia was saying we have such a turnaround of decision makers. We have countries changing complete governments from the very top to the very bottom every so many years. So we need to go on and create this capacity all the time. I think that is vital. But we also have the advantage now of technology, so we can incorporate the general audience, the general public on this. So we need to make sure that they have the capacity to understand data, to understand evidence, and to use it, and not just give it to particular decision makers that are in government. That's the point. So we need to make it democratic, this access to data and this access to evidence, so that everyone can make better decisions, particularly in health.
Thank you. And Felicia, you get the last word.
I'd ask them to recall, as some have already, that data points are people. And so in today's world, people who suffer diseases, people who speak for this, can speak out often, luckily, at least in our region and many places, more than they could before. And so my magic wand would be, don't just say it yourself. Ask those who are living it to say it for you.
Thank you very much. Let me just thank my panel for this, and I'm going to turn the closing over to my good friend and colleague and my boss, the Dean, Sandra Galea.
Thank you, Dr. Benjamin. Thank you to all the panelists, and thank you to the audience. You know, when one embarks on these 2-year processes of these reports, there's always this skepticism of like, why is one doing this? And you know, there's a lot of reporting happening in academic world and public health practice world. But I think the reason one does these exercises, and they're a lot of work, is to generate ideas, and it's to inflect how we think and what we think about, and to generate conversations that ultimately shape what we talk about when we talk about health. And I think if this report can do that, it can generate conversations like this one, which then we'll see among people who've participated, other conversations. Slowly, collectively, we will move in the right direction. I try to always remind our students that the work we do, when you're interested in population health, the arc of time is long. You have to accept the fact that you're changing things that matter to a lot of people, and it takes time. But ultimately, it requires good people, thoughtful people engaging with these conversations to make those changes. Thank you to all the panelists. Thank you, Dr. Benjamin, for being just that, for moving this forward in that direction. And thank you to everybody